Hello and welcome to today's Survive and Thrive presentation on preventative care and health maintenance to combat long-term effects of stem cell transplant. My name is Danielle, and I'm one of the oncology social workers that works at the Cleveland Clinic Cancer Center at our Fairview Hospital location. I support patients who are coming in for chemotherapy, and our doctors here in our clinic see patients who have hematology oncology diagnoses, gynecological oncology diagnoses, and urological oncology diagnoses. And I'm going to be helping to facilitate our uh, presentation today. And today we have Kayla Giannetti, who is here with us to present on the topic. She has been a nurse since 2013 and is currently a nurse practitioner in the blood and marrow and cellular therapy department at the Cleveland Clinic, and she's been in that role since 2020. Her special interests include cancer survivorship and older and frail adults undergoing stem cell transplant. She works hard to help patients survive and thrive post-cancer treatment, ensuring the best quality of life achievable. So we wanted to go over some housekeeping items for today's presentation. Any questions and comments we will have time to address at the end of the presentation. But throughout, if you would like to ask a question, you can click the raise hand icon and your name will be called, and please unmute your line to speak. You may also submit typed questions using the chat feature. And if you're experiencing any technical issues, please type a message in the chat for assistance. I'm going to be monitoring the chat as we go. And like I said, at the end, we'll have time for questions. Okay, and just some other ground rules for today's presentation. We'd like to maintain the confidentiality of all participants. So please respect the limited time we have today. Keep questions and comments relevant and concise. Please silence all other electronics. If possible, use your headphones and limit noise. Mute your microphone when you're not speaking. And in order to protect privacy and confidentiality, do not record, screenshot, or share the presentation on social media. This is a safe space for all. So the objectives of today's presentation are to, sorry about that, are to discuss potential long-term and late effects associated with stem cell transplant, review important routine health maintenance exams, review key monitoring, lab work, and diagnostics essential for health maintenance and preventative care, and discuss preventative care measures and important cancer screening assessments. I'm not sure I can advance the slide. Kayla, are you able to advance the slide?
Are you able to hear me?
Okay, we can hear you now. Okay.
Hi. Hello. Thank you for that introduction. And I really appreciate everyone that has been able to join us today, and for future participants and people who will be listening to this recorded lecture. As was already said, I'm Kayla. I'm a nurse practitioner here at the Cleveland Clinic Taussig Cancer Institute. Thank you for sharing those objectives. I do want to point out that some of these things will be specifically stem cell related kind of health maintenance and preventative care, but many and most of these things are actually generally recommended for any patient who's received radiation and/or chemotherapy. So I will start today by discussing the radiation-related effects. So we do often see that people can, years later, I shouldn't say often, but years later, people can experience radiation pneumonitis, which is basically a fancy word for inflammation of the lungs, and fibrosis, so some tightening of the tissue of the lungs. And that can happen years after radiation or right afterwards. We can sometimes see patients present with a cough, and this wouldn't be like a cough that, is like some kind of infectious viral thing. It's something that would be lingering on for quite some time. And even in the absence of cough, sometimes when your provider might be doing some routine radiographic studies like chest x-rays that can show some lung changes. For female patients, any exposure of radiation to the chest, or if they have total body radiation, they can be at increased risk for breast cancer. And second cancers can be associated with radiation in long term, and that can include but not be limited to things like skin, oral, and thyroid cancers. Before proceeding with more of these different topics as to like what these treatments can cause in terms of issues, I also just want to put out the disclaimer is, we truly do want our patients to live a long, happy, healthy life. That's why you're having this treatment, right? So we just like to empower our patients with this information so that they know what kind of health maintenance things to look out for, and so that their primary cares can also be informed. And if you're having any kind of these symptoms, you can bring those things up to your provider. It's better to be preventative and proactive instead of reactive. The sooner we know about these things, if they do occur, the easier it is to get control over those things, and the less likely it will be to affect your quality of life. For chemotherapy-related effects, we often see what's called neuropathy, peripheral neuropathy. It can happen in your hands and or feet. We can also have neuropathy in other areas of our body, but this presents usually as numbness, tingling, changes in the sensation of the skin, and particularly in the feet and hands. This can develop from treatment prior to transplant. If we're talking about a stem cell transplant patient from the chemotherapy they received before, and then it can also happen as a late effect post-transplant. If this occurs, it typically will continue to improve for up to 2 years out from therapy. Nerves are very, almost a little bit unpredictable as to how they will improve over time, those damage, and it takes a long time for those nerves to heal. For some people, that is quicker than other people, but know that it can take up to 2 years to really know if you're going to have any residual neuropathy long term. If it develops months to years out from treatment or worsens over that period, you should be evaluated by your provider to consider other contributing causes. And for example, things like high uncontrolled blood sugar can also cause neuropathy. Different orthopedic and non-treatment related things can be worked up by your primary care, for example. Cardiomyopathy is a fancy way of saying weakening and damage to the muscle, the heart muscle. Our heart is just really, truly a giant muscle. This is not common, but it can occur months to years out from the different types of chemotherapies that are listed there, including doxorubicin, cyclophosphamide, and treatments in the anthracycline class of chemotherapies. Symptoms of cardiomyopathy include persistent generalized swelling, specifically leg swelling, cough, or increased shortness of breath, particularly when you're laying down. Rarely we can see other blood disorders and cancers from secondary cancers from chemotherapy. This can present as leukemia or myelodysplastic syndrome, and symptoms can include things that represent low counts, such as unexplained bruising, bleeding, significant fatigue, or unexplained fevers or night sweats, or outward other symptoms that can be a sign of something else going on and something that you should be have some further workup from your primary care or your oncology team if you still follow closely with them. Kind of other treatment-related effects that isn't really like specific to chemo or radiation include organ damage that can actually happen with both high-dose chemotherapy and radiation. We give a very high-dose chemotherapy and sometimes radiation, sometimes not radiation, prior to stem cell transplant. And because this type of treatment is so strong, it can cause organ dysfunction. So that can present in the liver, kidneys, lungs, heart, and potentially lead for long-term dysfunction in those symptoms. So something to be aware of and kind of monitor through your healthcare team. Thyroid dysfunction. Your thyroid is a gland that is located in your trachea, your neck area, and this can occur after radiation or chemotherapy. Symptoms of thyroid dysfunction includes, basically symptoms of underactive or overactive dysfunction. Weight loss is associated with overactive thyroid. Weight gain is associated with underactive thyroid. Difficulty sleeping. Sleeping too much, anxiety and depression can also be representative of that. And blood work can be done to kind of tease apart if that's what you have going on. Bone loss, such as osteopenia, which means frail bones, or osteoporosis, which is a significant decrease in the density of your bones, can occur because of systemic or inhaled steroids. We know that those steroids are used for many different things. Sometimes it's used as part of your treatment regimen for your cancer diagnosis. Sometimes it's used for symptom management from treatment. For example, steroids can be used for rashes that might occur. Graft versus host disease is a transplant-specific thing that can occur, and the mainstay of treatment, at least initial treatment for GVHD, for systemic treatment would be steroids, and those weaken the bones more. Along those same lines, diabetes can occur with steroid use. Symptoms can include excessive thirst or hunger, increased urine output, increased neuropathy that we talked about, blurred vision, fatigue, dry mouth, and eyes. For blood clots, symptoms can include unexplained or new swelling, redness, or pain, particularly in the lower extremities, so your legs. And I just want to stop and make sure there's no questions in the chat so far. We're okay?
No.
Okay. For blood clots, blood clots can occur, and symptoms of those can include unexplained or new swelling, redness, or pain. Particularly, we can see these happen in the lower legs. These can also be associated with lines such as central lines to receive your treatment or transfusions. We've also can actually see it with IVs or PICC lines, which PICC lines are another type of central line that can happen that you may need for your treatment or follow-up transfusions, blood work, etc. after treatment. Hormone imbalances can occur as related to your chemotherapy, and that may disrupt ovarian function, so that would cause, could cause a woman to have a lower estrogen and progesterone levels. that those symptoms can be similar to menopause, including hot flashes, mood swings, vaginal dryness, and irregular periods. While less common, men undergoing chemotherapy may experience changes in testosterone levels, and those symptoms can look like fatigue, decreased libido, and mood swings. Finally, the last couple of things that can occur as related to treatments include deconditioning. So side effects of treatment and treatment-related complications can impact your overall physical health and strength. If you've had some bouts of periods of time where you've been hospitalized for a while and not moving around quite as much as you normally would, it's surprising how fast you can lose those muscles and your strength. And then some of the treatments can cause you to have some poor intake and nutritional deficits that can add to your deconditioning, your overall physical health and strength. Things like steroids can also affect your physical health and strength. So I hear this a lot, and one of the things that can be frustrating for patients include cognitive changes. And many patients describe this to me as brain fog and memory trouble after treatment. So those cognitive changes may or may not be associated with mental health symptoms such as depression, anxiety, and PTSD. So those are all different things to kind of look at in a holistic kind of way to tease apart. So this is specific to stem cell transplant for people who have an allogeneic stem cell transplant, meaning they got the stem cells of another individual. They can develop what's called graft versus host disease. They're also on immunosuppression, at least early on, to prevent GVHD, and sometimes need to either go back on immunosuppression because of development of graft versus host disease, or stay on it because of graft versus host disease. And the treatment for GVHD, as well as for immunosuppression, can have side effects that include a higher risk of squamous cell carcinomas, and so skin is a type of skin cancer that can occur in the mouth, throat, skin, and genital area. We see our patients have a higher risk of that compared to people who do not have chronic GVHD. So we'll talk a little bit more about that and what that looks like for preventative care. I know that this has kind of been a common theme so far, steroids, but steroids are great when we need them. Often they're very necessary for treatment of graft versus host disease and as part of other treatment regimens, but steroids have a lot of side effects. And we talked about a few of those already, but I also want to point out that they can increase your risk of cataracts, dry eyes, dry mouth, vaginal wall tightening. Avascular necrosis is what happens to a bone that can kind of alter, that can happen in your hip or your jaw. That's a degradation of that bone can occur over long-term use of steroids. Bone loss can occur, and that kind of goes hand in hand in what we talked about before. And we also talked about how steroids can weaken the muscles. We also can see skin tightening, which can lead to a decreased range of motion in the movement of your joints. And then metabolic syndrome and diabetes. Metabolic syndrome includes obesity. It can include high blood pressure, high cholesterol, as well as diabetes. We see a much higher risk of those things to occur for people who require steroids. And this I kind of talked ahead a little bit here. So like I said, we do have an increased risk for high blood pressure with immunosuppression, not only for steroids actually, as well as cholesterol. We can also see this with other immunosuppression, such as tacrolimus, can raise your blood pressure and cause some high cholesterol issues. Lung functions can also be decreased with chronic GVHD, and infections like CMV stands for cytomegalovirus. And we also see increased risk for shingles with chronic GVHD. So now, this is all information that is great to know, but getting down to the nitty and gritty, what can we do to prevent this thing from happening? And how should we be taking care of our health maintenance to ensure that we're preventing as much of this to happen as we possibly can prevent? And if it does happen, we really truly want to nip it in the bud early on so that it's not affecting your quality of life greatly. So if these things happen, getting them under control sooner rather than later, it makes it much less likely to affect your day-to-day. So the preventative care and health maintenance things that we'll talk about today include routine health maintenance exams, monitoring lab work and diagnostics, heart health, bone health, and endocrine health. Also, some other preventative health that don't quite fit in those different categories, and then cancer screening assessments. The routine health maintenance exams that are advised for all of our stem cell transplant patients, but also most patients who have undergone types of chemotherapy and or radiation for other types of cancers. No matter what, everybody wants you to see your primary care once a year, and that's to do things like monitor your cholesterol and your blood pressure and those kind of things, and then other health screening and cancer screening exams that we'll talk about in a little bit. For all of my stem cell transplant patients, I do recommend a skin exam at least once a year. After seeing dermatology, they may advise you to go more often if they have a certain finding and need to treat. All of our patients should have a dilated eye exam once a year. A lot of times, we already talked about some of these different types of treatment can put you at risk for things like cataracts. We can also see retinal changes, and then also some things if you develop diabetes, for example, dilated eye exam is important for that as well. For everybody should have an annual GYN exam, a pelvic exam. If you are a stem cell transplant patient, for sure. After a certain amount of after you go a certain age, eventually most people will not have an annual exam once a year, if you're getting in your 80s or something like that. So we look at your mouth during exams. Specifically for my specialty, we're looking for graft versus host disease mainly, but your dentist is looking for different oral cancers. So you should be seen by your dentist every 6 months for an exam. Other helpful collaboration may include people like endocrinology to help with thyroid and gland disorders and diabetes. Cardiology can be an important collaboration that we may advise you. Sometimes we also need rheumatology, and there are definitely other people that we collaborate with that we may consult depending on what you have going on. And I do want to also make the notation that although these are generally recommended at the time periods that are listed on this slide, sometimes exams need to be done more often. I kind of alluded to that when I talked about the skin exam. For our transplant patients, it's once a year. But say if you develop a squamous cell or a melanoma cancer in the future, the dermatology team is going to recommend exams more frequently. In terms of blood work and other diagnostics and monitoring, I do advise that routine blood work should be done, and this can be by your primary care, and sometimes your oncologist may also order these things as well, and that these labs can include CBC or your blood counts, metabolic panel that shows us your kidney function and your electrolytes, and then your liver function test may also be tested. Other things that may be indicated for you include TSH is used to monitor thyroid, A1C is a diabetes marker, your blood sugar over a 2 to 3 month period prior to having that drawn, a lipid panel, vitamin D to look for bone health. Hormone labs may be indicated for you, monitoring of your blood pressure. ASCVD risk, just to kind of discuss what that means, that stands for atherosclerotic cardiovascular disease, and that was a calculator that was made by the American College of Cardiology, American Heart Association. It basically, you input certain data such as blood pressure, gender. Are you diabetic? Are you on something for blood pressure? Your different cholesterol numbers, ethnicity, history of smoking, and it gives us this percentage risk as to you essentially like passing away from a major cardiac event, which would include a stroke or heart attack. And if that number is a certain percentage, then your provider may discuss with you starting a statin kind of proactively to reduce that risk of having that cardiac death of a stroke or heart attack. Mammograms are, used to monitor for breast cancer, PAP and HPV testing when due for females, prostate screening plus or minus digital rectal exam for male patients, and colonoscopy. But there are also some other acceptable alternatives such as Cologuard, and I would defer to your primary care as to what is the most appropriate for you. Bone density tests will look for screening for osteopenia, osteoporosis. CT tests may be indicated for lung cancer screening. Pulmonary function tests are done for patients who have had stem cell transplant. Radiation, they can be indicated for radiation. They can be indicated for lung cancer monitoring. And certain types of chemotherapy, such as busulfan, can affect your pulmonary function. And then some primary cares do some cognitive mental health assessments. In the stem cell transplant team, we also do some cognitive and mental health assessments, and that may consist of a number of approved different screening tests, such as the MOCA, and it's screening to see if you have any of those changes in your cognitive health, but also your mental health would be like what we call a PHQ 8 or 9 score, and that talks about depression and anxiety and those kind of things. Specifically for heart health, the recommendations is 150 minutes of cardio exercise per week, which is 30 minutes a day, 5 days a week. And the Mediterranean diet is also a lifestyle modification that's recommended for heart health. And I tell patients, you don't have to do 30 minutes of cardio exercise at one time. If you do 15 minutes in the morning and 15 minutes in the afternoon, that still counts. And kind of making yourself accountable in terms of coming up with a plan to increase your activity. You may start with 3 10-minute exercises for a couple weeks a week, and then increase that to 5 days a week, so on and so forth. Management of your cholesterol numbers and your ASCVD risk score would include things such as statins and other cholesterol lowering agents. We do recommend good management of your blood pressure, so that can include low salt intake and antihypertensives, management of your blood sugar, low sugar and carb intake, oral antidiabetics, insulin, and injectables all help with management of blood sugar. These are typically managed by your primary care. Cardiology specialists that could be involved in your care, depending on what you have going on, include preventive cardiology, oncocardiology, electrophysiology, and heart failure cardiology. For bone health, the recommendation is at least 2,000 units of over-the-counter vitamin D per day. Some people do require more vitamin D if deficient, and that blood work doing a lab test would be able to let you know if you are deficient in vitamin D. The recommendation for calcium intake is between 1,200 and 1,500 milligrams per day through diet and or supplementation. A lot of people get enough calcium in their diet, but for example, I get in about 600 milligrams in my diet a day, so I take a 600 milligram tablet, and that's how I get 1,200 milligrams. Regular weight-bearing exercise, such as walking and hiking, is important for bone health. Essentially, anything that your heel strikes the ground helps build and maintain your bone health. And sometimes treatment is needed, such as bone strengtheners, hormone replacement therapy, and testosterone. This is also often managed by primary care, but sometimes specialists that could be involved in your bone health include rheumatology, endocrine, GYN for like hormone replacement, and urology for testosterone. For endocrine health, so management of your blood sugar and bone health, as we discussed in previous slides, treatment of thyroid dysfunction, and this is another thing that is also most often managed by your primary care. Sometimes it does require some collaboration with endocrine and or rheumatology. These are other preventative health things for cognitive and mental health. Cognitive health screenings can range from simple to complex. Mental health includes screening for depression and anxiety. Some individuals do benefit from further workup and or intervention. This could include things like cognitive linguistic therapy that is done by a speech therapy team. Additional testing, like with the neuropsych team, sleep medicine can be helpful, psychiatry, and psychotherapy. For physical conditioning and strength, some individuals do benefit from physical health and rehab medicine. PT can be very beneficial for patients and is often indicated early for early intervention. Sunscreen and protective clothing for skin cancer reduction risk, immunizations, not smoking, vaping, chewing tobacco, or using illegal drugs also are important for making sure that we are preventing any kind of health issues. And then you should talk to your healthcare team prior to drinking any alcohol. There are many drugs that we give, not only chemo and chemotherapies, but other things like immunosuppressions and antifungals can interact with alcohol. So, but if you're off of those things, generally less than 1 to 2 drinks per day is okay. But again, I would always encourage you to speak with your healthcare team to get that okay from them before you consume any alcohol. Different cancer screenings. I do think it's important to point out that our cancer screenings we use the NCCN guidelines. So this is, these are the general recommendations based on our guidelines that are confounded with research and what we know based on the guidelines for our cancer. Our Cancer Institute relies on these guidelines so that we are ensuring that everybody's getting the appropriate cancer screenings, but your primary care should also be adhering to these too. I kind of already talked about prostate screening. So PSA is a blood test starting at age 50. African American males, or if you have a brother or a father that has had prostate cancer before the age of 65, earlier screening could be advisable, and this should be discussed by your healthcare provider if you are curious as to if that should be done sooner rather than later. Mammograms start, and that should be performed by ordered by your primary care starting at 40 years old. For women who've had radiation, that can start as low as the age of 25 due to increased risk of breast cancer. Cervical screening, cancer screening, you should have a pelvic exam by your primary care or GYN starting 1 year after transplant, but truly other disease groups, even if you've had colon cancer or skin cancer, you should be having this done as well. PAPS screenings are listed on there depending on your age. But your GYN or primary care doing your pelvic exam would do those tests at the same time if you're due for those. For our transplant patients, we do recommend skin cancer screenings, a full skin exam by your primary care or dermatologist starting 1 year post-transplant. And there are other different disease groups I would encourage you to ask your oncologist that yearly skin exams might also be indicated. And then for colon cancer screening, it's every 10 years, starting at age 45. And it might be recommended that you do it sooner, depending on what you have a finding for. Obviously, if you have a history of colon cancer, that screening is going to look very different. But for the general person, for the guidelines, say every 10 years, unless they find something in that colonoscopy starting at 45. Lung cancer screening is indicated for all individuals, even if you don't have a history of lung cancer, through low-dose CT scans starting at age 55. If you have a 30-pack year smoking history and you currently smoke or have quit in the last 15 years, and that screening can stop once a person has not smoked for 15 years. Oh. I think that was getting close to, yes, that was our last slide there. And again, I would just highly encourage you as a survivor to definitely follow up with your primary care regularly and your local oncology team, and have these health screenings done, because you truly did this to survive and thrive, much like what this whole lecture series is based on. And I want you to feel like your quality of life is good, and we're being as preventative and health promotive as possible, so that you have a good quality of life and a long, happy, healthy life.